the time out of your busy day and for continuing to prioritize the book club as we learn more about value-based healthcare. And thanks to everybody so far who has taken the time to, take ownership over a chapter and guide your fellow book clubbies through the content. And so for today's agenda, we'll jump right into chapter 5, and then Gilbert will be leading us through this dense chapter, and then we have Rose on chapter 6, and then we'll just remind ourselves at the next meeting and also on some next steps. So we had agreed on some next steps at the last meeting, and so we just need to touch base on those as well at the end of the meeting. All right, so for those of you who are on your computers, we do have some slides, and I've brought them up. Hopefully you can see them. Otherwise, they were sent via email, so feel free to take a look at those. And let's pass the mic, the virtual mic, over to Gilbert.
Thank you, Leah. So this very dense chapter, I will start off by saying one thing we need to know is that our frontline soldiers, I would call them, in this whole value-based competition is the physicians and the clinicians. Those are people we really need to target because they are the makers and breakers of the whole system. So in that light, we need to have process improvements in all aspects of delivery in order to reduce errors and complications, improve treatment outcomes, and boost efficiency, all in light of patient value increment. We should look at the patient outcomes as our target and our goals. What you see up is a strategic and organizational imperatives, which is basically the summary of this whole chapter, what providers need to do in order to fully participate in value-based competition. So for each organization, there is a need of a guiding strategy which helps to define the goals and purposes, defines the business and businesses it will as a provider operating, and define the services it will offer. It also has to find a way it will distinguish itself from the other providers. In that way, as a competition is, to get people to actually understand what you are into in terms of patient value. So without direction, it is very difficult to be truly efficient in operations, and clear goals and strategies should determine organizational structures, measurement systems, and use of facilities. So healthcare providers often suffer 3 types of strategic problems. These services are often too broad in terms of service lines. So what technically happens here is providers want to be a one-stop center to provide everything. I compare it to a buffet, a lunch buffet where you go into have lunch and there are all kinds of dishes. So you just pick and stuff onto your plate, but it's really not presented to you if it was an individual dish with all the added parts to it. So with that broad kind of healthcare delivery, there's really not so much focus on particular service lines, but a broad service line. So there's so many inefficiencies across the board, and so this is what we really need to change. So within that broad, while there are so many, like the broadness of the service lines, in the service lines, there is no specialization, I would call it, to actually maximize value in the service line that they are providing. So as they still give a broad, all size fit it all kind of service, within the service line, it's actually not specific. It's not really increasing value. So there's so much inefficiency and lost value across the chain. So overall, providers need to have, so what matters most is the experience, skill, and expertise in each service line, not the breadth or the breadth of the service line. So there's little justification to go back to the same provider for patients if for a medical condition they were at one time, they do not get the excellent conditions, addressing the excellent services that they need. So providers need to cut their teeth in providing excellent service lines to patients. So that's the whole thing, that the common mindset of providers now is to have everything inside. So when someone comes into the health facility, they get a bit of something, which is what value-based competition is all about. Value-based competition is all about how do you maximize the outcomes for patients when they come to your health facility or to your clinic, whatever you call it. So one thing that has actually been holding back this is the governance of physicians. So many physicians work for themselves, and this raises great challenges because there's no concerted effort to actually bring physicians on table to work as an integrated team to provide service and increase the patient outcomes. So I'll dive right into the strategic objectives, the strategic imperatives. So moving to value-based competition. So providers need to redefine their business around the medical conditions, just as you see what my slide is providing. What does this mean? It means that organizations should redefine should align their views on the value of patients. How are we increasing the value that patients actually get? Currently, systems are doctor-centric, institution-centric, and procedure-centric. There are treatment guidelines they pick up, and as long as they have a checklist that they tick off and say, okay, I did that test, I did that test, I did that test. So on paper, it actually looks like the patient has received all that is necessary. However, when it comes to the patient outcomes, so many things have been left out. So there's a misalignment between what is actually provided and what is actually creating value for the patient. So does anyone have something to say about that before I continue?
Well, okay, so can we get to some, can we boil some stuff down now from what you're saying? So what are the big takeaways from all this?
So one of the takeaways is that the health facilities need to I don't want to call it specialization as such, but should focus their energies on what their skills and what their staffing and training have to increase the value to patients in particular service lines, not spreading out their staff and their resources all over the place and actually missing out on increasing the value for patients.
So let's think about that in the context of our present system. I mean, I would be thinking that this is going to be a big red flag to the present system, the way it's structured, no?
Yeah, I think Gilbert pointed out one of the big challenges, as highlighted in the book, is how physicians are currently governed, organized, compensated, making that quite the status quo moving in this direction. It makes it challenging. For sure.
More than, I think that's an
understatement. Yes.
Yeah, I mean, I think we need to call it exactly what it is. That physicians want to make a lot of money, and they don't make as much money under this system the system being proposed, I suspect overall, as they do in the present system, although it's much less. Doctors are getting much different amounts depending on who the doctor is and what amount of time they're willing to put in and what specialty they get into and a lot of other things. But at the end of the day, they can have a big influence on how much money they make, depending on the decisions they decide to take. And,
yeah, and I think
this would basically turn our system on its head, right?
Yeah, I think whether or not they would make as much money or more money is not really known, but that certainly the fear of the change is there, and also the big piece is that whole shift in control that would happen from being, your own business to having to work in an integrated team, to be accountable for certain outcomes, to have, so that whole huge shift in control and the unknown about the money definitely, just creates a huge change barrier that would need to be really figured out. I'm not quite sure. I don't know if any government has who has.
I mean, there's just no way that these guys are going to raise their hands and say, "Oh yeah, pick me." I mean, this would have to be legislated. In the state? Did they legislate it? Like how did they get there? Do they just find kind of the willing groups and work with the willing groups? Is that it?
Yeah, Gilbert, what did you find? I know they mentioned, and I found it interesting, in Kaiser Permanente, so like in some of the examples that they're giving of organizations that are doing this, like Kaiser, all the physicians are salaried, and it's an integrated health plan with providers, and they've moved the physicians into a salaried model, so it makes it, feasible for them. But I don't know beyond that. Others, what did you guys observe?
So I wonder what the impetus was. I guess I'm sure they're well paid, but there must be other, I wonder what it was that sort of
convinced
them, yeah.
You see, value.
Go ahead, Gilbert.
Sorry. So the whole thing with this system is that it increases on part of the requirements from practitioners, especially in terms of reporting and measurements. And this in itself is an extra burden to physicians. It's like someone is watching over what they're doing in greater detail. So later in the chapter, you actually have the changing of the mindset right from the education system. How do we impart the education system, the training down from physicians up to before they come into service? How do we impart the value-based model into them?
Mm-hmm.
Yeah, I was going to comment on I think Louise's question. I'm reading between the lines for sure here, but given what I've read about various organizations across the world, banding specialty physicians and providers together, starting to implement value-based healthcare, is I'm assuming that these people are more business-minded physicians and providers who likely have a strong network of other physicians that are very good at what they do. And, as an entrepreneur, business-minded person, they realize that they can gather these experts together, the best of the best, pay them well, and attract a lot of new patients and clients to their practice if they can prove that they're providing outstanding service and achieving excellent outcomes. But all that is just surmising. That would be using Diabetes in the Netherlands as an example.
And so the whole point around, I think, education is huge. How are they being educated? And then once they're entering into the system, what's available to them. So unfortunately, the way, you know, in Ontario anyways, once you enter into the system, you can still choose to be a fee-for-service practitioner. You can still, or capitation, or, you know, there's that the system is currently structured in such a way that it continues to enable the problem. So to your point, Louise, if the system were to change, if even if it's not okay, even if it was a change management approach, where it's new physicians coming into the system, new specialists and new family physicians and other, you know, clinicians coming into the system, are coming into a system that is moving towards value-based. So they're being given options and choices for how they are going into practice and how they're being compensated for that are enabling value-based going forward. Even so, that means that the existing practitioners maybe aren't moving, but they're retiring. And so with them are dying those old ways of organizing and being compensated. You know, it would be feasible to shift the system, you know, that way, so it's not a huge jolt to everybody all at once.
But Leah, I think until people are compensated based on outcomes and not based on volume of services, nothing will change.
Yeah, absolutely.
That's it. That's exactly it.
No, absolutely.
So as Louise was suggesting, you know, the change in behavior has to come from being legislated to work in a different way. I don't think you're going to get people running up to a line to volunteer to do this out of the goodness of their hearts.
I think so, and I think it's really important to understand that, because, I mean, for a couple of reasons. One, you know, it might be at some point, I mean, this is something to kind of put on the, you know, parking lot list. I mean, do we try to, who's really been talking to medical associations about this idea of value-based healthcare? Has anybody? I mean, when I think about, you know, honestly, we don't really have them at the summit either, you know? I mean, I'm guilty as everybody, and that's kind of why we're going through this book, to figure out where are the gaps and where are the problems. But, you know, I don't know that I don't know how many of them are on board with, I haven't seen too many of them jumping up and down with this idea. Have you?
Yeah, no idea. I have a hard time imagining the OMAs of the world jumping up and down on this. I can more imagine Canadian Medical Association maybe being, you know, interested and sort of, willing to talk about it. I have a harder time seeing the actual unions doing the bargaining on the ground in the provinces being on top of it or being particularly excited about it.
Yeah, exactly. I think they're status quo kind of guys. So it's an interesting thought. I mean, we do have Rodney Burns who will talk about it. I mean, he'll talk about it that's different. And maybe that's a way in, is to ask him, you know, what is it that you think, you know, that makes the people who do it your way like doing it your way, you know?
Yeah. What I know from having worked with those physicians is that they are a very small subset within the Ontario Medical Association that are very that have very little power within that association, even amongst their peers.
Sure.
So, you know, in this case,
power, but we'd be interested to understand their motivations for notwithstanding all of that, deciding.
Totally.
You know,
yeah.
This is the way they want to go.
Absolutely.
Okay, that's very nice. What I take home from this is compensation needs to be taken away from volume to outcome, and that will really drive value-based healthcare.
Yeah, I think that's what we've been talking about here. Is that it's a whole, and that of course that also means that the other people, I mean, the governments pay for these services, and private insurers pay for these services too. So, I mean, they support the system as well. So I think that, those are two, they've really got to be on board with this and think it's a good idea.
Yeah.
So,
agreed.
The second imperative is the choice of the services, choice and type of services to be provided. And for a provider to choose what services, they need to look at the skill sets they have, the technology, and the patient mix, and see how they can achieve true excellence in terms of patient value, given those conditions. So institutions as a whole do not necessarily need to shrink the organization, but redivert or reorganize themselves such that they focus on areas where they can increase value as much as possible while freeing up these resources. Some service lines or would be limited or phased out in that whole process, all actually shifted to a better provider, a person with better excellence in that service. John, I think, has a question here. I don't know.
Yeah, he has. He asked whether or not anyone in the States, if we've asked anyone in the States about buy-in with physicians and how this was achieved. I think it's a good question that maybe could ask Scott Wallace to consider as part of his comments at the summit. I don't know.
Absolutely.
Yeah.
So, thank you. So in terms of implementing the service line choices, depending on what provider you are, for example, academic medical centers tend to have a whole broad spectrum of services they provide due to their nature of the work they do in terms of training incoming physicians and different medical personnel. So service lines in academic institutions, academic medical centers technically will be different from those in community medical centers and those in rural, providing rural services. So community hospitals should medically integrate in terms of with other medical centers and looking geographically where they are located, how best then can they strategize in increasing value for particular service lines. So, for example, most...
let me ask a question though. Doesn't this come back to medical schools and governments again? In terms, I'm not an expert on this at all, but I gather that governments only allow a certain number of people in medical school and a number of people in particular areas of medicine and all of that. So isn't this gonna have to get designed at the government level again, or am I misunderstanding this?
So with medical schools, from my experience, depending on what resources need to be there to train practitioners, for example, the facilities, your facilities actually limit you to the number of people that can use them at a particular time. So that's why I think most medical schools have a maximum number of people they can actually employ at any one time. But in this time, what I was talking about in terms of medical centers, academic medical centers. So most academic institutions providing medical training are attached to a hospital, a medical hospital, which where you have the students coming in to learn about different medical conditions. So specialization in particular service lines in those academic institutions becomes a problem, because then you have to maybe collaborate with different medical center to have students go to those other medical centers in order to learn about practice there. So that's what I was talking about.
Yeah, in the book they talk about how academic medical centers, are also too broad, and it's to enable that training. And so yes, they would, if the more specialized they became, the ability for students to learn would require a lot of different partnerships and them moving across different institutions to do that.
I
think,
like,
Louise, you're making the point about, yes, there is, at least I don't know about it globally, but certainly I think my understanding is in the provinces and in Canada, there is a degree of control that happens about how many physicians of what types are able to enter into the system at any time, et cetera. I believe so. And I know certainly in Ontario, they've increasingly been in the family practice side, which this is more focused on the specialist side, but in the family practice, they've been limiting what types of models of care that they can practice in and what geographies they can practice in. That's relatively new, and the OMA has hated it.
Yeah.
So,
yeah, of course.
Yeah, of course.
Yeah. So I don't know, it seems to me like this is kind of a big, a sort of I don't know if it's a matrix or what it is, but there's so many things that impact this whole business of doctors and how they do their, work, that there's so many players that are like a matrix, sorry, the government, the schools, the hospitals themselves, how they are constructing themselves and what they take on as specialty areas. Just seems to me like there's a lot of, and there's going to need to be some sort of a meeting of the minds of all those gangs, aren't there, in order for us to ever get anywhere?
Yes, to your point, and at a degree of design consensus across the different players. I mean, that's really what the book's arguing fundamentally is, the principles or whatever, the core attributes of value-based healthcare that needs to be common consensus across all these players, so people start working on the same page. Because making this even more complex, to your point, when we talk about medically integrated practice units, this isn't just physicians, this is all sorts of clinicians and other types of, and this is administrators and facilities, and so this is physicians working with other types of providers as well, which is already very challenging. And in the current zero-sum system, with the bargaining power of different associations, from the nursing association and the physician association, et cetera, the way it currently works, until people get on board and say, yes, we want to achieve common outcomes, across the cycle of care, and we're gonna, and the costing, we agree to what the care cycle is and how the costing is going to work across all of us. You're never going to be able to sort through all that complexity, and you'll stay in this zero-sum competition. So how do you start getting that meeting of the minds so people agree and have some consensus about, we agree that value-based healthcare, is what we're trying to achieve. This is what it means, and how are we all going to contribute towards that over time is a big question.
Well, I mean, who's really got the power, I guess, is my question. Like,
well,
where's
Louise,
the power?
Yeah, I was going to say the same. In a corporation, to achieve anything that's innovative, you need executive sponsorship. You need a leader with a vision, and without that, nobody's going to band together and do this.
No, I know, but we're not in a corporation on this.
No, but just using it as an analogy, we need leadership. Leadership.
Oh, we always need leadership. The question is, how do we get it? And who's really the action? That's what I don't, I'm not, who is the action here? Whose leadership do we need? Mm-hmm. And that's the thing, no question about that. Leadership is going to be the name of this tune all along. But I just don't think we know who they are yet. Like, maybe we do, but you know what I mean?
And in Canada, because we do have single payer systems, you could say government could take that role, or governments, but as we know, that would be incredibly challenging.
Well, they won't.
Exactly, the political will to take on all these groups,
Yeah, that's
across
the thing.
multiple jurisdictions would be really challenging to do.
Yeah, no, yeah. That's the problem we've got is that
So
there's so many powerful players here that you know, there has to be an impetus that, you know, there has to be a groundswell, and that's why I haven't yet concluded that it isn't going to have to come from us, you know. Oh, just 1 second. I'll just be 1 second. I'll come back on.
Yeah. Let's keep going. It's a good question. I'm just, you know, where's the power and whose leadership is needed? And it coming from patients is a really good point, but I think Louise has also made the point in the past that patient groups also, in many ways in the current system, at least in Canada, has the least leverage or the least power in the systems as well. So what would that look like? As we also talked,
they don't want to use up, they don't want to use up any markers very easily.
Any markers?
You know, they don't want to call in markers, you know, no governments or anything call in markers until they have, you know, it's got to be worth it for them.
Yeah.
So, you know, that's the problem I think we're going to have. And I'm still not convinced that the only people who really want this to happen are us. And I guess the pharmaceutical companies, it's always a joke that we always end up on the same side of the table with them in a way. I mean, it is and it isn't. I mean, it's not that unusual, but it just always seems a bit so strange to me that we always end up on the same side with them.
Well, I think you raised a good point, though, of medical associations and, is there a way, even if it's at the national level, even if it's the Canadian Medical Association and the Canadian Nursing Association and these sorts of groups, to start with before getting into the actual bargaining power at the provincial levels, is there a way to get some early leadership of some of the provider groups as well?
That's what I'm wondering. Well, and unions, I wonder if it is, we don't have to start, or it isn't important for us to start having meetings with, that's why I try to, when I think about these things, I try to think, who's the who in all of this? And, not so much even what's the what, but who's the who? Because then, you can start having meetings with them.
Absolutely. But I do think, and, I do think that the provider groups are important to approach for sure. And probably we get more traction with the national ones than the provincial unions. At this,
the provincial ones.
We know, we know and then we could learn from the national groups about where they think there might be opportunities or early adopters in any of the provincial groups and relationships that can be leveraged and that sort of thing. Pharma, we already know is on board, but to your point, if it's just patient groups in pharma that are going at this, no, people are going to write it off. Unions potentially, I don't know, what do you think about, we're going to get into chapter 6 shortly, but health insurance groups, is that they're probably not going to be early adopters of this, but CLIA, I mean,
but we might as well know what they
yeah.
They might as well know what they're thinking.
Yeah, we'll get there. Yeah, I think, it almost makes sense to sort of take, at least at the national level, as we're going through the rest of this book where they're talking about all the key stakeholders. I mean, I think really approaching the national associations that represent these stakeholders to say, where are you at with this? Is it on your radar? And, and what's your level of support? And just starting to understand where people are at and where the opportunities are would be a good first step.
I think we have to start the conversation somewhere.
And then you can see where is the leadership, right? So, and where can there be some leverage? And
Absolutely.
All right. So Gilbert, if you want to wrap us up, I think we're jumping all over because we've all read the chapter for sure, and you know, it's
So
what are some other big takeaways from this one, Gilbert? Did we lose Gilbert? Did he give up on us?
so sorry. No, sorry. My network seems to be dropping. I don't know.
Yeah, there's something going on with your phone.
Can you hear me?
Yes, it's a little broken up now, but we can hear you still. Oh, not anymore
Start
though.
my go-to meeting and see if it will sort it out.
Oh, it's good now. All right, I think Gilbert's dropping off and coming back. Let me see what his other slides were as well. Okay, here they are. Is that you coming back, Gilbert?
We lost him.
I think so. Oops. I also want to say hi, Stephanie. Welcome. I think Stephanie Michaud joined us.
Yes, I did. My apologies, I was 10 minutes late. Thank you.
Don't be shy. Feel free to jump in on the conversation.
Thanks, Leah.
Hi, Gilbert. Are you back?
Yeah, I'm back. Sorry, my network seems to be dropping.
Oh, you're sounding good
I
now.
think I'm much better. I think the next thing we really need to pick out from this chapter is the issue of the measurement of results, experience methods, and patient attributes. So really the hallmark for the value-based healthcare is providing people with real evidence showing that there's actually a need to shift to value-based healthcare. And the only way you're going to do this is by actually doing measures that show an improvement in patient outcomes. So many providers now are shifting towards collecting some kind of data to support their interventions. So there is a need for providers to take ownership of collecting, analyzing, and actually disseminating data to different stakeholders.
So this is back to the old. So this is back to the old data problem.
Yeah.
Yeah.
Back to the problem.
Data and accountability and transparency. Yeah.
Yeah, all the data problems.
Yeah.
That's really
so we're on top of that, I guess, for the conference. We're going to talk about that.
Yeah, we need to look at strategies for the real world also. How do we actually start working on it? So
yeah, so we'll stop there for a second. Have we got somebody going to talk to us? I keep forgetting. I know we've got the Kai-Hi folks coming, right, Rose?
Yeah, we do, Louise. Yep.
Are they going to talk real world?
Yep.
Who's talking real world?
Yeah.
Okay, great.
Hi.
Okay, perfect.
Yeah.
Perfect. So the last bit of it would be integration within regional geographical integration and readjustment for different providers, where especially rural providers who don't actually have the volume of patients and skill sets should integrate with different providers within the same or within a geographical region and enable information share, patient referral, and specialize in where they give the best value outcome for patients.
I really,
the last bit of.
yeah, I really liked something they said in there because it's something that I felt for some time when I was dealing with the Ontario Hospital Association and their approaches to strategies for rural hospitals, is that I think part of what I was reading in this chapter is part of what I was feeling and saying as well, which is that they should actually be connecting themselves with centers of excellence, using technology, gaining actually becoming experts in more areas as well. So really doing their job better in those rural regions and bringing rather than being everything to everybody. So being that broad service line again, which is, generally speaking, in Ontario, the strategy that I've been seeing is that they're going to take over everybody's role and do everybody's role in that geographic location, as opposed to we're going to become connected with other hospitals and other facilities, other hospitals that using technology, using different ways of having that expertise brought into these rural regions, and having that specialized approach. So I really resonated with that part of it. Yeah, but it's certainly against the trends of what I've seen play out in Ontario anyways. But whatever, who cares? So it's because the trends that are happening in Ontario aren't going to bring the outcomes you're looking for patients, right? So the other one I think is that this whole piece of the payment, moving to single bills, and how are you paying? This whole concept of bundled payments, right? How are you paying for the whole care cycle instead of for individual interventions, right? And how are facilities charging for that? And I think governments are doing more work on that than most other things, right? They're trying to figure out accountable care organizations and bundled payments. That's where there's some movement, though I think limited in some governments, is to figure out the payment side of things. But I wanted to ask a question of Gilbert and the group, just something I heard when I sat and met with Rod Burns' group and a bunch of other mental health and addictions associations and stuff from Ontario. Is what they have been hearing about value-based healthcare from sort of top health researchers in Ontario, people like Walter Woodkiss, I'm not sure how to pronounce his last name, is that they're looking at value-based healthcare as something that is possibly only going to be good or appropriate for single conditions because of this whole focus around medical conditions, and they're kind of writing it off as something that can apply towards more complex, comorbid, people who are living with multiple conditions, basically, which is a lot of the population. They're struggling to see how value-based healthcare could apply in those contexts.
But I thought that's exactly what they did say in the book, is you split people up into those different types of populations. The young, the old, the comorbid, the chronically, like they have a whole list of different ways of dividing your population, and then you work out health outcomes that are realistic for that population. So surely it can apply anywhere if you want it to. I mean, that's what I understood from the book.
What I read too, what I read is they basically said you specialize on a medical condition, but where there's common co-occurring comorbidities with that condition, you develop the expertise in those areas too. That's how I read some of it. I don't know about others, but
I don't know if I don't know whether you develop the expertise So, but you get the expertise.
You bring it in. Yeah.
It becomes part of your team, right? In whatever way is the most practical and appropriate for the situation. Is that not right?
Yeah, and then I was also reading, then you further, where you have different patient populations, that's where you can get even more strategic in terms of your sub strategies, so to speak, and your sort of lines of service would be to figure out, okay, well, it's different for people who are low income or people from this different ethnic background, different types of requirements or whatever the case may be. So, or elderly people. But yeah, I think just from a system and researcher perspective, I think there's a struggle for people to see this beyond hips and knees or just individual, diabetes or just individual single conditions.
Well, then why don't they go back to the source of the book and ask them how to do it?
Yeah.
I mean, somebody figured it out. The people who wrote the book say they figured it out, and can Andre and his gang in the States and ICHOM help them?
All good questions. And I don't know, the people in the book, it's still it's still basically at this stage when the book's being written, in theory. So I guess the bigger question is those like the Kaiser Permanentes and others who have started implementing it, how have they addressed
that's right.
that?
That's another place. Go to places that have actually implemented it.
And I think
We're
maybe
not
again,
solve that one for them, but they should find out a way to solve it.
Yeah, I think we're coming up with good questions to pose to different summit participants, though.
Yeah. For sure.
Because these are the things in people's minds. So the more we can bring it out in the conversation at the summit, I think it would be good.
Oh,
Did
yeah,
other
no
people?
question.
And Gilbert, I know you still also wanted to cover, oh, hold on. We've got John chatting us. Hold on. Let's read what he's saying. All right. Ooh, John, you've got lots to share. Okay, I'm going to read John's comments. I know on a really limited small area that individuals within the states now travel to healthcare institutions based on reputation and expertise. I belong to the Atrial Fibrillation Forum of the AHA. And then he gave a link. Most patients share information on who is good, what should I as a patient look for in managing disease. I often hear about people now traveling to Texas, etc., plus Cleveland Clinic. From around the states, I assume I'm seeing results of a move to value-based care. And then his next comment was, does that really work for rural, sparsely populated areas? One almost becomes emergency medicine specialist with referrals to major centers of expertise.
True.
That's kind of where it's, yeah. And then last comment, I think with chronic conditions, you might have case management hubs that link with individuals in homes, including rural areas. These hubs, which serve multiple chronic conditions, could be linked to various hospitals or providers. I assume the funding then gets split and billed as cost centers. Yeah, I mean, this is some of the concepts around accountable care organizations. You're working across different, and bundle payment is, you're working across different facilities to deliver the whole package.
Well, yeah, this is one of the things I've raised this a couple of times, is that one of the things they say in the book that nobody believes they said in the book, and I'll have to read the book again to find.
Oh, they do say it about the need to travel. Yeah.
Yeah, that at
do.
the end of the day, that it may be that, you know, you're going to have to travel to get care if we're going to split things up in this way and try to get sort of hubs of excellence or centers of excellence, or call it whatever you want, that people, there will be some need for travel. But I agree with you, John, entirely, that doesn't, you know, that we can create our, if we really are building kind of teams, some of those teams may be virtual, right?
Oh, absolutely.
Yeah.
And they'll have to be. It's part of the challenge of what's happening in the Northwest, though, too, is that they're looking to create, I think that the Northwest LHIN in Ontario has been trying to interpret some of this and trying to do some of this. But what it's looking, you know, the Northwest LHIN, for those of you in Ontario who don't know, it's a huge geography, very sparsely populated. A big chunk of it is northern, you know, fly-in, remote First Nations communities with no road access, who have basically next to no service at all right now, other than being flown into Sioux Lookout, which is a big sort of hospital hub in the north. But they're looking at trying to implement value-based healthcare. They've been working with Scott Wallace and others, but the way it's been working is it's basically increasingly people are going to have to go to Thunder Bay, and there's no and currently within the system there's no proper funding or for transportation as it currently stands, and there's no real approach that seems to be putting into place of, well, if that's going to be the case, how are you going to overcome the insurmountable barriers people currently face to get to not even Thunder Bay, but to get to, say, Sioux Lookout, or to get to Dryden, or to get to
yeah, exactly.
So it's really hitting huge resistance on a lot of different levels. Plus, they're also taking other approaches that are pissing people off, with hospitals taking over everybody in other smaller geographical areas and stuff. So that whole point about travel and rural and remote, I think they talk about it in the book in different places in different ways, but there's definitely that message is in there of people will travel for the best. And I think people are willing to travel for the best, but it's only if they can. And in some geographies and some income and et cetera, certain determinants of health, it's just not feasible. So if you haven't actually put the system in place to make this easy for people, they're not going to get the care. Full stop.
That's it.
And that's part of the danger of how this rolls out. If people aren't willing to actually invest in areas where there currently is no investment, things like transportation, this will not work. It'll cut more people out. So the people who can get it will have better outcomes, but more and more people won't be able to get it. The people, certainly in the lower income areas or with poorer determinants of health. Right. So I'm glad you're absolutely raising it, and I did see it in the book, and I've seen the whole piece around rural, remote, and travel sort of dealt with differently. And I think, Rose, in your chapter, it comes up as well, and it's basically kind of like people, that the health plans, since they're looking at it through the American lens, are going to have to, pay for travel expenses, basically, is what they're saying.
Well, I think there's loads of implications here. So is that, are we over to Ruth yet?
Also, just one last thing was about the barriers to value-based healthcare, and looking at things like the attitudes and mindsets are places we really need to focus into and see how best to bring people on board to appreciate value-based healthcare.
Right.
Yeah.
The rest, I think, comes in once all the attitudes are changed, then the regulation and governance and all that will be a result of changing people's attitudes towards value-based healthcare.
You're right.
Yeah. I think
basically people wanting to do it, the rest will follow, right?
Yep.
Yeah. Yeah, you're right. Number 5, attitudes and mindsets.
Mm-hmm.
John is saying, and only if they are aware of who is the best. In Canada, if we are not committed to outcome results, including publishing this, then people do not know where to turn. Absolutely. It's like you're just calling up your people to find out who's the best. Exactly. I think we have only,
exactly.
Yeah, Louise knows all about this. I think we have only published mortality rates once for hospitals in Ontario. Yeah. Thank you so much, Gilbert. This is a huge chapter. We really appreciate you taking it on, and you lost your partner in doing it midway through. So it's really appreciated. We only have half an hour left, so let's get Rose up and running, and I'll just bring up her slides in 1 second. Here they come.
Okay.
All right, Rose. Thank you again, Gilbert.
You're welcome.
Yeah, thanks, Gilbert. So similar to chapter 5, chapter 6 was a bit of a beast as far as the number of pages and the amount of information that it covered. I signed up for this chapter because, of course, like many of us, I have a health plan through my husband because I'm an independent consultant. But I've also worked on the other side of prescription drug claims at TELUS Health, where TELUS Health adjudicates a huge portion of prescription drug claims across Canada. And I was on the analytics team there, but also over the 3 or so years I was there, got a taste of what the private health plan world is battling as far as sustainability. So similar to our public plans for drugs, sustainability is definitely on the minds and has been for many people, especially with high-cost drugs coming into play. So for those of us lucky enough to have a health plan, we know that health plans are the bucket of additional coverage that our quote unquote universal health care plan in Canada doesn't cover. That was a stab and a joke at the same time. So health plans are covering many more drugs than the public plan covers. Health plans cover all services that OHIP doesn't cover, in theory, like physiotherapy or massage, dental, eyeglasses at times, you name it, health plans cover it. So having said that, I think we're all aware that health plans, similar to our healthcare system in general and the whole zero sum, are trying to find ways to shift costs and minimize those costs because the healthcare services that they cover are still viewed in our world as a commodity instead of finding ways to improve outcomes for people and find ways to keep them healthy over time. I did find the read of this chapter a little bit challenging at times because there's a big difference between health plans in Canada and the U.S. One being that in the U.S., of course, health plans also cover hospital care and physicians and specialists, where in Canada those services are covered under our public system. So there were
that's a good point.
Yeah, there were a lot of references to simplifying billing and, a lot of administrative overhead with respect to paying all of the care that it's covered under a health plan in the U.S. So I found that a little bit challenging at times, but that's okay.
Yeah, I tried to read it with two eyes as this applying in Canada to both basically government payers as well as private payers, because a lot of this chapter applies to both, or maybe not at the same time all the time, but certainly both types of payers end up in the Canadian ecosystem being implicated by this chapter.
Yeah, exactly, Leah, and I did the same. Yeah. So I think skipping to the sort of the end of the movie, as they say, the next slide. So in future, the huge recommendation in this chapter and what it's all about is moving health plans from being administrative and processing organizations to true health organizations. And what they mean by that is basically health plans would really become the driving force to organize, evaluate, and facilitate medical care across the full care cycle, which is a huge shift from what they are today. The recommendation is that health plans would take a lead role in compiling and analyzing member health results over that full cycle as well. So that's a fundamental, very significant change that sees health plans sticking around in Canada, contrary to what our National Pharmacare program is recommending. Seeing health plans stick around, but also taking on a much broader, more important role where they're actually sort of the stick handler, the leader, working with individual patients and facilitating and finding and gathering all the information about their journey through the health system. So I found that quite compelling, and wondering, how the heck are we ever going to get there? So next slide, Leah.
So how are we going to get there, Rose? Don't stop there.
I didn't have any dreams or thoughts about that yet, Louise. Maybe throughout this conversation.
Well, I guess the big thing is to figure out who needs to be in the room to answer that question, right?
Yeah.
I think, yeah, it's taking us back to our earlier conversation of where's the power, where's at least the early leadership that we need to bring together to actually start to get some consensus on this across the different players.
Yeah. So I don't know if everybody's aware, but I'm going to go off slide for a minute. But not only are there insurance companies in Canada that offer health plans to, small and large employers across the country, but there's also a couple of other orgs. Green Shield Canada is a not-for-profit who offers health plans, and there's Medavie Blue Cross as well. In addition to the Sun Lifes and the Great West Lifes and the Manulifes of the world, those other two organizations also offer health plans to employers. And having worked in that private sector, having intimate knowledge of at least the prescription drug claim area of health plans, health plans are always looking to minimize costs, as I said before. They're struggling, and they are looking to benefit consultants to work with the employers to find ways of saving the plan money. That isn't working all that well because benefit consultants don't have all the information they need in order to have all of the, we'll call the real world evidence at their fingertips to be able to inform employers to make the right decisions. There are tools out there like plan simulations where an employer can request their health plan provider to run a simulation and change some parameters around the health plan to see if that will impact members as far as out-of-pocket costs and reduce their own costs. So there are tools out there that help inform them, but of course they're not 100% accurate. Employers aren't really taking an active role in trying to maximize the experience for their plan members, for their plans. It's just not many organizations' priority to really take a look at their health plans and what they're offering to their employees to make sure that it's the right one. So it's typically, a one-size-fits-all. Everybody gets access to the same sort of benefits in their health plan. And of course, as people know who have them, you can choose the 2 or 3 different levels, and the different levels don't change what you have access to, but it just changes what percentage of your benefit is covered and how much you have to pay out of pocket. So there's a lot of issues out there today with respect to health plans in Canada. There's a lot of complacency by the plan sponsors or the employers as to having any focus on their health plans, even though everybody talks about health plans being one of the things that attract people to companies. There's not a lot of proactive. Yeah, go ahead, Leah. I'm
decreasingly hearing that. I mean, some of the people I've been talking to for our private payers working group, benefit consultants, etc. They're really hearing from the employers increasingly and are developing the mindset themselves. I think a really depressing one of really, this is not, it's not effective retention and recruitment. This is not our core business. Why are we, there's more and more of a mindset of why are we doing this? And and we should be doing less of it than really sort of stepping up to the plate and saying this is about our employees and we need to do more. So it's sort of the vibe I'm getting anyways, is that there's an increasing stepping away by employers of this and seeing the value of it. And I think the more that things like pharmacare take that type of approach, it's going to increase that trend to say, like, let's just shift it all then to the public payers. Why are we even in this business in the first place?
Yeah, I don't know. Maybe from an employer perspective, definitely not from an insurance company or plan provider perspective, because they need that business. That brings in a lot of revenue for them. So I guess having said that, we'll get back to the slide unless anyone wants to comment or question anything so far.
No, go ahead.
Okay, so according to, some of what I read in Chapter 6, the vision for health plans in a value-based healthcare world would be that they have a very unique and essential role in BBHC. As I said previously, they would change from just being insurance orgs to health orgs, and from just payers to actual participants. They would measure and reward providers based on results. They would maximize the value of care over the full care cycle, especially if they're going to have all the information at their fingertips and have all the analytics on each patient's outcomes available. So they would also minimize the administrative aspect of their role and somehow simplify billing. I don't know. Yeah, I mean, obviously, IT would help with that. So one of the key messages that, I found fascinating was that they would compete on member health results. And I wasn't able to really wrap my head around that, because today, if you work for an employer, they say, you can opt into their health plan, but their health plan is provided by a very specific insurance company or health plan org. So I'm not really sure how that works or how that could work. Or maybe I've misread it. What I'm assuming on this one is that they're saying that, they would, if they can prove that they're creating more healthy people, that members could go out and shop for which sort of health plan insurance company they want to align with. So that's a huge difference as to what's happening today. Did other people read that way or a different way?
No, I didn't read it that way. So what is it that you understand?
I thought, Louise, when they said compete on member health results, that basically an individual like you or I, if we worked for a company offering a health plan, that we could basically shop around and say, we don't want to join Great West Life's health plan. We want to join Sun Life's, because Sun Life is proving that they've got better health outcomes for their members.
Yeah, and I don't know if this is more of like an artifact of the American sort of thing.
Yeah, I'm wondering about that.
Where there's more people purchasing individual versus through their employer, where in Canada we have more people getting it through their employer. I think maybe in Canada it would mean that it would be more, it would make, for employers anyways, there would be more competition in terms of more data-based competition that could help drive employer choices about who to go with. There are individuals that purchase their own health plans in Canada too, but I don't think the percentage is as high as in the States, anywhere near as high anyways. So it's a bit hard to, I think, wrap our head around it as a result. Yeah. Oh, hold on. Do we have a comment coming in? John, yeah, is this by employer? I think in Canada it would be more at that level, yeah.
Yeah, it would have to be. So yeah, again, it's difficulty with some of their recommendations, trying to Canadianize them, because they're just completely different concepts, the way things work in Canada versus the US. The last bullet on this slide, says provide health information and support to patients and physicians. So it would be new to provide support to physicians in the Canadian world.
Yeah, they also had a role for care coordination, I think, in there too, which again, I could, might apply for some health plans, but really care coordination, certainly the trend that I'm seeing and where it makes a lot of sense in the Canadian ecosystem is, for it to be embedded in health providers themselves, in the facilities, that they are actively coordinating care for patients, not just within their facility, but across the entire cycle of care. So, in the book, they were putting a strong emphasis and sort of giving the role of care coordination to health plans. I don't know if that would actually work in Canada per se. I definitely would see it as a role for providers, and certainly it's a growing trend, and needs to be, because it's a huge issue. People cracks, full stop. So.
To that,
yeah, exactly.
To that comment, Leah, I think they gave an example that Cigna is offering in the U.S. is offering a nurse health advisor program that provides telephone, email, and mail communication between a nurse and a patient. And that nurse provider would provide outreach, education to patients before and after hospitalization, guidance on health risk assessment and health coaching, et cetera, et cetera. So interesting concept that role would be provided by a health plan. I don't know if we should discount that and say that it would be provided within the provider world in Canada. I think we have to think outside the box and really question whether or not that makes sense in Canada, and whether that would be perhaps maybe a more objective place for this role. I don't know.
Yeah, I agree with you entirely.
It would mean then the public plans would have to be doing it. Then every Ministry of Health would also be your care coordinator, right? Because for people who don't have the private coverage, and you're getting it anyways. Just so it.
Okay, but Leah,
yeah, it's a question.
I'm going to challenge.
Yeah.
I'm going to challenge what you just said, because I think in the value-based healthcare world, I read somewhere in the book that I think everybody, or maybe I've got other reading material mixed up in my brain, but there's a concept that going forward, everybody is part of a health plan. Even everybody, no matter how much money they have, the very poor to the very rich, are forced to have a health plan, and that health plan could be partially funded by public. So in that case, then what you just said wouldn't apply, because you would have everybody as part of a health plan.
Yeah, like in Quebec, whether it's private or public, everyone's part of a health plan. But anyhow, we don't need to decide where care coordination lives, because again, if you move towards value-based healthcare, that function has to be fulfilled in order for a person to make it successfully, to have the successful outcomes, to make it across the entire cycle of care.
Exactly.
Care coordination has to happen, and I know that within the provider world, care coordination is receiving a lot more attention and investment, and there's a lot of good stuff that's happening, and I would not want to stop it. And the more you would get the consensus in moving to this approach, the more people will figure it out. You don't have to, it would, to the earlier point, if you got the mindset shift, you get the rest of it would sort out, and it doesn't even have to look the same in every place. It's just, but everyone would get what they need. So.
Mm-hmm.
Oh, but John, our problem is convincing insurance providers that it is in the best interest to provide this level of service. Oh, hold on a second, sorry. There was an earlier comment from John. The concept, however, reduces costs in the long run. If I eat better, live better, and eliminate the risk factors, then I become less costly to the plan. Our problem is convincing insurance providers that it is in their best interest to provide this level of service.
Mm-hmm. So there are some health plans that are actively capturing and promoting wellness data and programs. And I think, in an altruistic way, they're trying to begin that, John, and try and educate and promote healthy living with the members. Of course, with any new program, it can be done well or it can be done poorly. And I think that some out there are being done quite well, and some aren't really taking hold just because of the way that the employers are launching the program, how they're promoting the program. They're not incentivizing their members to participate. People need incentives, even though, because I think a lot of people want to be healthy, but there are a lot of people who want to be healthy but don't want to take too much action. So,
yeah. John wrote, altruistic or addressing social determinants of health. I would also add that it's in the interest of plans to be putting forward good, wellness and prevention, or even sort of, disease management, chronic management type of programs, because it will slow the spend, so to speak, on other high cost items. So the less people need to actually take certain kinds of drugs or, access to other types of costs that they would be paying for, because they're better managing their health earlier on, or, preventing disease or better managing diseases, the better for the plan ultimately. But he also asked about addressing determinants of health. Anyhow.
mm-hmm.
Thanks, John. Sorry, we can't hear your voice. Okay, we have 7 minutes left. Go, Rose, go. Unless people are willing to go a little bit later.
Probably not, I'm sure. Okay, so there were 3 steps the book said health plans can take. And the first one is providing health information and support to patients and physicians. So again, as per the theme throughout the book, organize around medical conditions, not geography or administrative functions. Develop the measures, assemble the results, information on providers and their treatments, actively supporting the providers and their treatment choice with information, counseling, organizing information and patient support around the full cycle of care. That's also a theme throughout the book. Providing comprehensive disease management and prevention services to all members, even healthy ones. So, as we were just talking about. So then number 2 and number 3, so restructure the health plan provider relationship. So, like the third bullet, move to single bills for episodes and cycles of care and single prices, absolutely. Simplify, standardize, and eliminate paperwork and transactions. I'm sure that in any healthcare setting, the paperwork is just killing people, literally, and their ability to be effective providers of healthcare. I'm not going to read them all, but going down to number 3, redefine the health plan subscriber relationship. So this was an interesting concept, moving to multi-year subscriber contracts. So
That's huge.
Yeah, so as everybody's aware who has a health plan, every year you have to reapply and reselect your health plan coverage. And in this new world, they're saying, no, that's not good. Create a contract over multiple years so that you can actually, capture and keep plan members in a single health plan so that you can actually have longitudinal data on their health experience, their healthcare experience.
Yeah, because the value, the outcomes are not going to be achieved necessarily within 1 year, right? So it's the wrong time horizon. Yeah, and it's huge. That whole annual renewal process is problematic. So that one shift would be enormous to multi-year contracts.
So the second bullet, I'm not familiar. I don't have any insight into the re-underwriting issue that was spoken about in the book. I don't know if anyone on the call does. But that was another way to end the cost-shifting practices. And of course, re-underwriting, basically reduces trust in your health plan. and makes people cynical that, you know, they're going to be covered. So, Lee, it's 1:27. Do you want me to go to the last slide? I don't know if anyone wants to comment on these steps.
All good.
Okay, so what would be different? I captured a few things. So extending healthcare coverage. So one example, which was spoken about earlier, paying for travel. So patients can obtain better health outcomes elsewhere. I think, you know, there was a point where, you know, people think that patients are passive about their healthcare, but they're actually not. I think if they have the right information and say, you know, if I can travel 100 kilometers and get the best outcome I can possibly get, or, you know, get that same treatment locally within 5 kilometers and take the risk that it's not going to be so great, I think I'd choose to drive the 100K if I had the means, right?
Yeah.
And I think that's the big, if I had the means. A lot of people don't, even if they had the information, they wouldn't have the ability to travel due to expense and other, you know, complications. Yeah. Health plans may choose to offer additional counseling as a premium service for plan sponsors who want it. Health plans can use the care delivery value chain. I think that was described in a previous chapter, to map the cycle of care, identify linkages among different providers, labs, and service organizations involved in care. I mean, this is really, if we could ever get to this, this would just be so amazing for people. And anticipate gaps in coordination. I think that's one of the huge pet peeves of patients today in all disease areas, is the gap in coordination of care. Not only coordination, but information, having to keep, you repeat yourself at every appointment, giving the same history and background that you just gave at the 5 previous appointments to different providers. Shifting the nature of information sharing with providers. So leveraging prescription drug claims, because those can really offer a lot of opportunities to, about compliance with medication or adherence, which is a big problem at times with medication, prescription drugs that people are taking. Health plans can assist physicians in gathering outcome data before making referrals. That would be quite amazing as well. One place to find, you know, the performance of another person. That'd be awesome. Health plans should also share with physicians ongoing feedback about the results achieved by their referrals in terms of patient outcomes. That would be great, of course. And then providing resources to support those physicians in terms of diagnosis and treatment. So then I had some questions for the group, but it's 1:30, Leah. I don't know if we want to just end the call.
Yeah, I think that was great. Did anyone have, we'll do a little bit of wrap up, but just to open it up, did anyone have any last comments before we wrap up? Okay, Fabiana stating that, oops, where did that go? I saw a note come in from her, but I don't, here we go. Okay, so Fabiana's leaving. She has another meeting. She'll see us in the next meeting with chapters 7 and 8, which actually Fabiana will be leading chapter 7 with us. So thank you so much, Fabiana, for stepping up to do that. Unfortunately, Kathy Kovacs-Burns is no longer able to participate in the book club, so you're solo on that one, unless anyone wants to volunteer to work with Fabiana. And for chapter 8, we have Alan and John on board. So John, I'll be in touch with you to figure out the tech issue so we can hear you for that. And I'll be in touch with you and Alan so you guys can connect and coordinate together. Our next meeting is on September 27th at the same time, noon Eastern. Just wanted to flag too that we had agreed to do some homework on our last call of just sort of reorganizing or reclustering the different principles in chapter 3, is it 3 or 4, I think? Anyways.
Really 3, I think, isn't it?
Yeah, but unfortunately, nobody actually sent me their homework, so to speak. I understand how busy everyone is.
Yeah, it's because I was sick. So,
no, absolutely. So we'll go work on it.
Yeah.
Yeah. So
it's actually next on my list.
great. So I'll send out a reminder. I'll just keep it on people's plates so that we get it, that we work on it before the end of our book club meetings. And I want to thank you, Rose, so much. That was, and Gilbert, that was fantastic. Those were two really dense, important chapters that you guys tackled there. And I think we had a great conversation. So I want to thank everybody who joined today, but especially to the two of you for that extra work.
Thank you.
Thank you very much.
Have a great day, everyone. I look forward to our next meeting on September 27th.
Great day. Bye-bye.
Yay, thanks, Lisa.
Happy reading.
Thanks, everyone.
Bye.
Bye.